Hi, this is Tom, and welcome back to the Zero to GP channel. If you're new here, welcome. If you're not new here, I hope you enjoy this video and do consider subscribing to the channel and following as more videos come out. In this episode, we're going to be going through Progestogen-Only Contraception, all the key stuff you need for your GP exams. As always, the format of these episodes is I'll ask you questions and I want you to come up with your answer in the gap. Ideally, say it out loud or write it down so you know whether you actually know that information, and then I'll go through an explanation. So let's jump straight into this episode on Progestogen-Only Contraception. The first case is a 34-year-old woman, and she comes into her GP because she wants contraception. She's otherwise well, but she does have a family history of a deep vein thrombosis, which affected her mother. The first question is, what would be the UK MEC, which is the UK Medical Eligibility Criteria for contraception, for the combined oral contraceptive pill? The UK MEC for the combined pill, if there's a first-degree relative with a history of venous thromboembolism, like we have in this case, is 3. So the risks would outweigh the benefits in this patient for the combined pill. So it wouldn't be recommended. My next question is, what would be the UK MEC for the Progestogen-Only pill? The UK MEC for the Progestogen-Only pill with a family history of deep vein thrombosis is 1. So the Progestogen-Only pill is not known to increase the risk of venous thromboembolism, so DVTs and PEs. However, the combined pill does increase the risk. So in this case, the Progestogen-Only pill would be fine, but the combined pill would be too risky. So it should be more suitable for Progestogen-Only contraception. My next question is, what are the Progestogen-Only contraceptive options? So there are 4 types of contraception that contain only progestogens. They are the pill, for example, desogestrel, the injection, which you have every 12 to 13 weeks, which contains just progestogen, the implant, which gets inserted, it's like a little matchstick inserted in the upper arm typically, and that releases progestogen, and finally, the levonorgestrel intrauterine device. So this is a coil, for example, the Mirena coil, and that releases progestogens just locally inside the uterus. My next question is, what is the mechanism of action of progestogen-only contraceptives? How do they work to prevent pregnancy? So they have 3 main mechanisms of action. The first is that they inhibit ovulation. Not all of them inhibit ovulation. For example, the progestogen-only pill doesn't typically inhibit ovulation, although with desogestrel, a lot of women do stop ovulating. But that's not the main mechanism for the progestogen-only pill. And with the intrauterine system, so the Mirena coil or other progestogen-only coils, they don't always inhibit ovulation. They do in a small number of women, but that's not their main mechanism of action. But for the implant and injection, they do inhibit ovulation. The second mechanism of action is that the progestogens thicken the cervical mucus. So there's a mucus plug in the cervix that prevents sperm from getting past the cervix into the uterus and then the fallopian tubes where they cause conception. So if the sperm can't get through the cervix, pregnancy can't occur. And then the third mechanism of action is that they thin the endometrium, which makes it less accepting of implantation and less likely to develop into a pregnancy. Okay, so we've got this 34-year-old woman, and she wants to start the progestogen-only pill. My question for you is, when do you start the progestogen-only pill? When should this woman take away the pill box and start taking it? So she can actually start it any time of her menstrual cycle. But there's some key things. If she starts on day 1 to 5 of the menstrual cycle, day 1 being the day that she starts bleeding, if it's day 1 to 5, she's immediately protected from pregnancy. So that's a great time to start it because she doesn't need to think about anything else. However, if she starts after day 5, firstly, she needs to be sure she's not already pregnant. So she hasn't had any unprotected sexual intercourse since her last period. That's one way. But there are other ways to tell that she's not pregnant. For example, she's had let's say she's not having periods. She's had a pregnancy test at least 21 days since her last unprotected sexual intercourse. However, we're overcomplicating things. We'll get onto that. But if she's after day 5, she'll need extra protection for the first 48 hours of taking the pill. So with a progestogen-only pill, it takes 48 hours for that cervical mucus to thicken enough that she's protected from pregnancy. So if she starts in the day 1 to 5, she's immediately protected. After day 5, she needs to use extra protection, for example, condoms, or avoid sexual intercourse for at least 48 hours of taking the pill. Hope that makes sense. Okay, on to the next question, which is, what follow-up would you arrange in general practice as a GP after initiating the progestogen-only pill for the first time? The guidelines recommend following up at 10 to 12 weeks. And this is to check everything's going okay with the pill, no adverse effects, managing to take it on time, and all that kind of stuff. Okay, on to the next case, which is a 28-year-old woman, and she's 2 weeks postpartum. She gave birth 2 weeks ago. She wants contraception. First question is, can you start the progestogen-only pill at this point? So she's 2 weeks postpartum. You can start the progestogen-only pill at any time after a woman gives birth. She's immediately protected from pregnancy if she starts the progestogen-only pill within 21 days of giving birth. So they say you can't get pregnant 21 days after giving birth. You won't ovulate. So if you start the progestogen-only pill during that time, she's immediately protected. This is in contrast to the combined pill, which you can't start until 3 or 6 weeks after giving birth, depending on whether you're breastfeeding or not, because of the risk of venous thromboembolism. Okay, on to the next case is a 46-year-old woman, and she's had no periods for the past 4 months. The next question is, how are you going to exclude pregnancy in this patient? So she's 46 and no periods for the past 4 months. She may be perimenopausal, which is why there's a large gap between her periods, but she could potentially still get pregnant at this age. The key way to exclude pregnancy is that she's had no unprotected sexual intercourse in the past 21 days and she has a negative urine pregnancy test. If you have unprotected sex and then you do a pregnancy test within 21 days of that unprotected sex, there could be an early pregnancy that's not yet producing enough HCG to make a pregnancy test positive. So it needs to be 21 days after the last unprotected sexual intercourse to exclude a pregnancy. Okay, on to the next case. The next case is an 18-year-old woman. She takes the combined oral contraceptive pill, and now she's switching to desogestrel from the combined pill. Maybe she's come in with new headaches or migraines, and it's decided on a risk-benefit analysis that is better on the progestogen-only pill. So she's switching to desogestrel. My question is, when can she start the desogestrel pill immediately? When would it be fine to switch straight from the combined pill to the desogestrel pill? So there's two scenarios where she could switch directly. The first is if she's in week 2 or 3 of the combined pill, meaning that she had the hormone-free interval, she's had the full first week of the pill pack, the full 7 days, and now she's in week 2 or 3. At that point, she could stop the pill and the next day start the desogestrel pill, and she'll be immediately protected. The other scenario is if she's in day 1 or 2 of the hormone-free interval. So she's finished the pill pack, and now she's on day 1 or 2 of the hormone-free interval. At that point, she could just immediately start taking desogestrel, and she'd be protected. Let's say a different scenario, she's currently on day 3 of the hormone-free interval, and she tells you she's had no unprotected sexual intercourse since the start of the hormone-free interval. In this scenario, how are you going to switch her to the combined pill? So the recommendation here, if you can do, is if someone's on day 3 plus of the hormone-free interval, then they'll need additional protection for the first 48 hours. So they can start the desogestrel pill straight away, but they'll need additional protection for the first 48 hours. Now, the caveat here is that they need to have had no unprotected sexual intercourse since the start of the hormone-free interval. So let's say she's currently on day 3 of the hormone-free interval, and she had unprotected sexual intercourse yesterday. In this scenario, how are you going to switch her to the desogestrel pill? So in this scenario, she's not necessarily protected from pregnancy here because she's had unprotected sex and she's on day 3 of the hormone-free interval. So the way to switch here is to restart the combined contraceptive pill and then take it consistently for 7 days and then switch to the desogestrel pill. So she's past day 1 and 2. If she was on day 1 and 2 of the hormone-free interval, she could switch immediately, start desogestrel, and she's protected. But because she's day 3 or above and she's had unprotected sex, then she needs to restart the combined pill and take that for 7 days. And this is to suppress ovulation. And then after she's been taking it consistently for 7 days, then she can switch to desogestrel. In some scenarios, it may not be appropriate to restart the combined pill. For example, they've developed migraines with aura. And that's in this scenario, you can quick start desogestrel, but you'd need to consider emergency contraception and a urine pregnancy test at least 21 days after the episode of unprotected sexual intercourse. And of course, you would need additional protection for 48 hours after starting desogestrel. Okay, onto a new scenario. We've got a 25-year-old woman and she wants long-acting contraception. She doesn't want to be taking the pill every day. My question to you is, how long-acting is each option? So you're going to have to give the long-acting options of reversible contraception and how long those are valid for once you have them. Okay, so there's 4 long-acting reversible contraception options. So let's go through each one of those. The first is the injection, for example, Depo-Provera. And this injection lasts for 13 weeks in terms of protecting against pregnancy. So they say you need a new injection every 12 to 13 weeks. It is kind of potentially lasts for 14 weeks, but officially 13 weeks. And they recommend a new injection every 12 to 13 weeks. The second is the implant. For example, Nexplanon, which is that little matchstick that goes in the upper arm. And this lasts for 5 years. The next one is the levonorgestrel intrauterine device, for example, the Mirena coil. And these devices, there's quite a few of them. I believe there's 5 currently in the UK market. And they last a varying amount of time from 3 years up until 8 years. So the Mirena coil, once it's put in place, it protects against pregnancy for 8 years. And the final one is the copper coil. Depending on the device, this will last from 5 to 10 years. So the longest potential one is a copper coil that lasts for 10 years. The next question is, which one of these long-acting contraceptives can cause weight gain? The only one officially known to cause weight gain is the injection, for example, Depo-Provera. My next question is, which 2 of these long-acting reversible contraceptives require caution in a patient who's younger, for example, younger than 18? So the coils, meaning the levonorgestrel intrauterine device or the copper coil, are UK-MEC2 in patients under 20. And the reason they require caution for coils in patients under 20 is there's a higher risk of expulsion. So a higher risk that the coil will pop out and then it won't be effective and won't protect against pregnancy. The injection, the DMPA injection, is UK-MEC2 in patients under 18. And the reason for this is that it has the potential to reduce bone mineral density in patients under 18, where their skeleton is still growing and hardening. If you give them the injection, there's a risk that it will thin the bones, and the sort of anti-estrogen effect will mean that the bones are not as strong. My next question is, when are you going to start these long-acting progestogen-only contraceptives? So here we're talking about long-acting progestogen-only contraceptives, meaning the implant, the injection, or the Mirena coil, the hormone coil. If you give them or insert them on day 1 to 5 of the menstrual cycle, then they're immediately protected. If it's after day 5, they need to use additional protection for the first 7 days. So unlike the progestogen-only pill, which requires additional contraception for 2 days, the long-acting ones require additional protection for 7 days. Okay, onto a new case. A 23-year-old woman who started the progestogen-only pill 10 weeks ago. And she's come in because she has unscheduled bleeding. She says, I'm having bleeding like a period, but it's kind of erratic and I can't predict it, and it's not so good. My first question is, which key tests are you going to consider in this patient? So 2 key tests. The first is a sexually transmitted infection test. So you can do a urine sample or swab, particularly testing for chlamydia. You can test for others like gonorrhea as well. And the second one is a pregnancy test to exclude pregnancy. My next question is, are you going to perform a speculum or pelvic exam in this 23-year-old who started the POP 10 weeks ago and is having unscheduled bleeding? Now, this depends if the bleeding is quite obviously or very likely due to the pill and is kind of typical unscheduled bleeding associated with progestogen-only contraceptives. You don't need to, or you aren't recommended to perform a speculum or pelvic exam until the bleeding has persisted for more than 3 months. It's not necessary to perform the examination. However, you would consider performing an examination if the woman has not had cervical screening, because you want to have a look at the cervix and make sure there's no cervical pathology, for example, cervical cancer. If the woman requests an examination, then you would perform that for her. Or if there's other symptoms that will make you suspicious about other pathology, for example, pain or post-coital bleeding. In these scenarios, it's worth performing an examination. But if it's typical progestogen-only contraception-induced irregular unscheduled bleeding, they don't necessarily need an examination until the bleeding's persisted more than 3 months. You can assume it's because of the contraception. Okay, on to the next case. You've got a 19-year-old woman. She's had the implant, the progestogen-only implant, for 6 months. And she's been having unscheduled bleeding during that time. You've examined her and performed some testing, for example, STI testing, and these are all normal. So you're not concerned about any kind of pathology other than it's the implant causing this bleeding. What options do you have to manage this bleeding? She doesn't want to have the implant taken out if she can avoid it. So what can you do instead to manage the bleeding? There's 2 options here. The first is you could give her mefenamic acid, which is an NSAID that helps reduce the bleeding and shorten the bleeding time, which she could take when the bleeding occurs for up to 5 days. So she starts having an unscheduled bleed, takes mefenamic acid, and it will shorten the bleed. The second option is to give her the combined oral contraceptive pill on top of her implant. And you can use that for up to 3 months to kind of get control of the bleeding and then hope that the bleeding then stays settled after that's stopped. Okay, and on to the final case, which is a 21-year-old woman. She takes the progestogen-only pill and she comes in because she's missed a pill. My question to you is, when is the progestogen-only pill classed as a missed pill? At what point would you say she's missed the pill? This depends on the type of pill that she's taking. For the traditional progestogen-only pill, for example, levonorgestrel pill, it's after 3 hours. So if she's 3 hours or more late of taking the pill, she's missed that pill. But for the desogestrel progesterone-only pill, it's more than 12 hours after the scheduled pill time. And for the drospirenone progestogen-only pill, it's more than 24 hours after the missed pill. My next question is, what's the missed pill advice you're going to give this patient taking the progestogen-only pill? So she needs to take the missed pill as soon as she remembers and then continue with the other pills in the pack at the normal time. So this might mean taking 2 pills in the same day. She'd also need extra protection, so avoiding intercourse or using condoms, additional protection for 48 hours until she's been taking the pill regularly again. So the 48 hours until she's established back on the pill. And if she's had unprotected sexual intercourse, you need to consider emergency contraception. So if she's had unprotected sex since the missed pill, she could be, the cervical mucus could have thinned enough that it's allowed the sperm through, and she could be susceptible to pregnancy. So emergency contraception should be considered. Final case or final question is a 21-year-old woman, and she comes in with a positive pregnancy test. And she's been taking the progestogen-only pill. Maybe she's missed a few and she's not been taking it perfectly. She's become pregnant. And she says she wishes to continue with the pregnancy. What advice would you give this patient? So she's a pregnant woman who's been taking the progestogen-only pill. She should stop the progestogen-only pill. And it's worth noting to her that the progestogen-only pill is not known to be harmful to pregnancies. So women who got pregnant while taking the progestogen-only pill, it's not known to harm the pregnancy or cause any issues with the baby. She'd also need other pregnancy advice. For example, make sure she's taking folic acid, vitamin D, books in with the midwife, and so on. So thanks for listening to this episode on the progestogen-only contraception. Hopefully it was helpful. A few resources for you if you're preparing for GP exams. The first is the AKT revision book. This book covers all the key topics you need for your GP exams. There's also the zeroToGP.com website where I go through where you can find questions, flashcards, a fact trainer tool, and notes for your GP exams. And I've got an upcoming revision course in September in London where we go through the whole GP curriculum for the AKT exam. So check out those resources, subscribe if you're not already subscribed to the podcast or the YouTube channel, and I'll see you in the next episode.